everybody. Welcome to the session we are hosting on combating health inequalities in a digital age. Thanks for joining us. I'm Dr. Dan Bunstone, and I'm a GP based in Warrington, Chief Medical Officer for Push Doctor. There's three of us presenting today. Jess is with us, Push Doctor, and Dr. Ivor Singh, who is lead GP at HMC Heston down in Hounslow. Just a little bit of housekeeping before we begin. I suspect you've been on calls before, but if you could remain muted, raise hands for questions. We'll take questions at the end through chat. We will try and collate if there's any trends, and then we'll deal with questions at the end if that's okay. So great, let's get going. So whereabouts are we at the moment? I'll have the next slide, please, Jess. What we wanted to look at is the problems currently being faced in general practice. Gosh, I suspect the problems being faced by many of you are legion, but ultimately a lot of this boils down to primary care facing huge, overwhelming demand on the back of an already overstretched, overworked, and indeed decreasing workforce of GPs. COVID has made this situation significantly worse. And of course, there's been quite a bit of unhelpful conversations in the media around it too, which hasn't helped the situation. That's impacted directly negatively on recruitment, managing, and clinical supervision. Recruitment to the ARRS roles has proved a challenge too. The funding for ARRS through the PCNs has been a magnificent boost and a real clear opportunity for us. However, that's got to be balanced against the difficulties in recruiting roles. Not all areas have the same problems, but indeed some of them will have. Yet this all builds a picture of where patients will start talking about primary care being closed, primary care not being open, difficulty accessing primary care, etc. We all know very well that primary care has been open for the entirety of the COVID pandemic. We've done a whole load of work with the vaccination program, but of course the perception still exists out there, incorrectly of course, but it gives us real significant problems in primary care. And I guess there is that whole problem at the moment still where some surgeries, some of us still face that problem where patients still either view the GP and the nurse as the only good outcome for their phoning the surgery. And of course, patients tend to get signposted in that direction. We know from ARRS funding, we know that allied health professionals are a massive boost and a real clear asset that we should be using increasingly more. Next slide, please, Jess. I'm doing my Chris Whitty, of course, today. So the view is very clear. What we need to be doing is trying to get patients in front of the right clinician at the right time, at a time that is convenient for us and indeed for them. So what we've drawn out here is a rather basic and dumbed down map of what things could look like. So what we've got on the left-hand side, of course, as a potential solution is your PCN. Frankly, the size of the PCN doesn't awfully matter. It could be 30,000 patients, it could be 300,000 patients. What is important is the surgery maintains its sovereignty. And the colour coding, which I'll move on to next, the roles have been split up. Either they already exist in primary care, which is blue, so there's no additional cost because they're already funded. It's a funded role, which is green, so additional support from the ARRS, or of course there will be a service with an potential additional cost to it. So ultimately what this map looks at is how we could manage demand in a better way, getting the patient in front of the right clinician at the right time. All the surgery's information, all the surgery's triage notes would go to a centralized triage hub. And what's important here is not everything goes there. The surgery does some soft sorting too. So any admin-based work will still sit at the surgery. Any clinical-based work would go to the hub. We've split that out, of course, into a triage team and digital signposting. Excuse me. What happens after that, of course, is then you get the patient in front of the right service at. So, of course, this could be a video pharmacist if they need a consultation, or, of course, it could be a clinical minor ailment service. Push Doctor offer digital minor ailments with well pharmacy. So what that means is if a patient has a minor ailment that is amenable to pharmacist intervention, patients can be directed to a well pharmacist online, have the consultation, and the pharmacist will have access to their GP medical records. That's a real sea change in the past because, of course, the pharmacist then is allowed to make a decision with the backup of having the full medical record. And of course, digital signposting could also send you towards a physio. That speaks for itself. MSK, amenable condition, off you go and see an MSK physio. We currently partner with an organisation called Pure. Work that we do with them, 90% of their consultations are dealt with by TUE. And by that, what I mean is, let's say I attended with left shoulder pain. In 90% of cases, that will be dealt with, treated, managed, and fully sorted by TUE. Around about 5% of the individuals, they need some prescribable painkillers, and an additional 5% might need some additional scanning. That could be X-rays, ultrasound, MRI, etc. Compare that to where things are now. That's a massive improvement in how things are being dealt with. Significant improvements too for your CCG, I guess, with regards to how many people are being scanned and scanned at the right time. And of course, ultimately down on the bottom layer there, there's the opportunity for pharmacist video appointments, GP video appointments, and of course, some of the traditional GP face-to-face too. Clearly, this map isn't the full detail. There's no mental health practitioner on there. There's no paramedics. There's no nurses. Absolutely get that. This is more of a descriptive thing. And actually, you can cookie cut. And by that, I mean, you could put your mental health practitioner MSK, or you could put a paramedic in the minor elements. It just describes the picture. Next slide, please, Jess. So I guess what we are very aware of is we come to the table with some real clear solutions. We can support with digital locums, we can support recruitment of ARRS, and we can support with the minor ailment service in tangent with Well Pharmacy, or indeed any of the local pharmacies. What we recognise, though, in trying to reduce those inequalities that we face currently, with people being unable to access services, unable to fully access the ARRS, what we do not want to do is to create another inequality by having patients who can't sufficiently access the digital technology. That's something we work incredibly hard on. The NHS has identified here that 20% of patients, or people indeed, lack the basic digital skills to use technology sufficiently. That's something that Jess and her team have been working really, really clearly on. Somebody said, Dan, my signal keeps dropping out. Gosh, I'm in central Manchester. There's not a lot I can do, only apologise for that. So I'm really sorry. I will carry on. And if you have any questions at the end or I drop out, please somebody flag on chat for me. That'd be really useful. Yes, I think I'm going to pass over to you at this point. No, I'm not. It's still me. So looking at what the barriers are to digital inclusion, of course, there's a number of reasons. Motivation, move away from the traditional face-to-face, feels irrelevant, not sure in the ability to be able to handle the condition they've got. Of course, confidence, stepping away from their trusted GP who they've always seen face-to-face for years, and not actually being sure that they're going to be able to get the service they need from the digital GP. We know that not to be the case, but it's these barriers that we need to overcome. Very practically, access, of course, even based in central Manchester, it would seem that Wi-Fi doesn't always hold up, and of course I'm being let down slightly here now, but that's one of those things. Again, access is a number of reasons. It could be inability to access it, or indeed the Wi-Fi if you're in a particularly rural part of the country. And of course, let's speak to the digital skills piece. Not everybody has that ability to use the internet, or the clear knowledge or confidence indeed of using the services. Next slide, please, Jess. So this is definitely where I do pass over to Jess. As I've touched on before, we know there are problems that can be created by digital exclusion, but of course, there's lots of solutions we can provide to that too. Jess, over to you.
Great, thanks, Dan. I'm actually in the same office as Dan, just in another room, so please let me know if the internet does drop as well. So, hi everyone, I'm Jess. I lead the design team here at Push Doctor. I've been working with the business for over 3 years now, really enjoying working in the health tech space, embracing all its challenges, hopefully to deliver, finding solutions to deliver better patient care. So Dan's spoken about some of the problems and the barriers that people have been facing around digital exclusion. So I'm going to talk about some of the solutions that we've been looking at here as a design, product and engineering team. So since we launched the NHS service, I think it was back in 2017, we've always had a really clear focus on accessibility and ensuring that our product and our service can be easily used and accessed by as many people as possible. But through COVID and everything moving to remote consultations and the research, a lot of the research coming out about digital exclusion and the health inequalities gap growing and has grown in the last year and a half, we as a digital healthcare business set out an initiative to find solutions that will help break down those barriers to digital consultations and allow just not the tech-savvy young people to embrace digital healthcare, but also we want to be able to access a wide range of people across different communities and allow them to get the same access to services as some other people who might be a bit more tech savvy. So this bit of a technical difficulty there. So this initiative was timed really well with our partnership with Hounslow. And the nature of communities within Hounslow that once we delved into required probably quite a high level of digital inclusive approach. So when we started the project, what we wanted to do is set ourselves like an objective. So what did we want to achieve by looking at digital exclusion? So we set ourselves this aim, and our aim is to be as inclusive as possible, meeting the health needs of our partners and their patients, helping to close the digital exclusion gap and promote digital empowerment. So for us as a design team and also as a business, it's not just about creating that access, but also we want to be able to help and support, educate by empowering patients that might need that additional support to access digital health services. So once we'd set our objective, we wanted to look into who were the groups of people that were being digitally excluded. So we engaged in quite a lot of research. We looked at the NHS report that had come out in around July 2020 around digital exclusion. We delved into Hounslow as an area, really looking at the demographics, pulling out health equality reports. We spoke with Healthwatch, who were also doing quite a lot of different research projects in London and nationwide as well. And we spoke with patient participation groups. So this was really great for us as a design team to try and help empathise with users and really get some feedback and ask them questions like what might be the blockers, what might be the barriers, what would your frustrations be about accessing digital services, but also health services within their area. We surveyed our own patient experience team. So we asked them like who are the people they speak to patients every day, so we asked them who are you speaking to, like what are there anybody with any frustrations, like how could we help them, like really getting advice from people who are on the front line and speaking every day to our users of our current product. And we also spoke with practice managers in front of house within our partners. So there were 4 key groups that have been identified as people that as groups of people that have been digitally excluded. So we've got non-English speakers, so people who do not have English as their first language. So these are being identified as a group where, especially during the pandemic, they've been reported to have 90% more problems accessing healthcare than maybe some other groups across the UK. Then older people, some older people are unfamiliar with technology and how to use it. They may be fearful or confused by online services. So we know there was quite a lot of different tech scams going on, especially during COVID. So they're a bit fearful of giving over their information, like how it's going to be used, how, like what's going to happen if they click a link within a text message. And then we've got people on lower income. So they might not have access to digital products. They might not have the latest mobile phone or iPad. They might not even have access to the internet. So these are definitely a group of people that could potentially be digitally excluded. And we know that by looking at some of the recent data, there's been 17% more healthcare disruptions reported by those in manual and routine jobs than there has been versus, say, managers and professionals. And we could see this within the Hounslow area, where a lot of the staff had been furloughed because they work at the airport. And, there was kind of a crisis with that within the Hounslow area as well. And then finally, people with disabilities. So these are definitely a group that potentially needs some help and support accessing different types of online services. So once we'd identified the different groups of people and focused and done our research and empathized with these users, we started to look at the different solutions that we could create in our product and services as Push Doctor. So the first one is multi-language. So for patients who need the translation support, they will be able to request an interpreter to join the video consultation in seconds, excuse me, alongside the GP. So this is fantastic for patients who maybe English isn't their first language, or for big kind of PCNs where they have a mixed ethnicity group, and would be able to get that translation service inside a video consultation. Then the next one is our digital ambassadors. So we've already got an amazing patient experience team that I spoke about earlier. But what we looked at doing was taking 3 of our patient experience team and enabling them to be, and training them to be digital ambassadors. So this means that a patient can book in an hour slot with a digital ambassador. They will take the time to talk through technology setup, do a service walkthrough, or even just moral support. So we found this would be a really good way for some of our older patients who might just need help in the first consultation or setting up or creating their account. They want to be able to access the services, but sometimes they just need a bit of additional support getting set up. And that's what those digital ambassadors were there and set up for. We've then got our digital pods. So these are safely designed private rooms, which include an iPad, which is connected to the internet, where patients can easily consult with a clinician by video. So this is for those maybe people on a lower income, or for some elderly patients who don't have access to, for those patients who don't have access to devices, that might be able to, they can walk into their town hall and, walk into a pod, and then they'll be able to access a video consultation. This also goes hand in hand with the digital ambassadors. So we're looking at creating digital ambassadors outside of Push Doctor that maybe sit within the town hall and sit where these pods are, that will be able to help patients get set up and walk through the service with them as well. Sorry. And then finally, we've got our AA+ certified accessibility. So this, this is a level of compliance that an app or website should meet to allow as many people as possible to access their service. So it can be looking at font sizing to ensure legibility, color contrast, clear errors, or direction. And most importantly, and at the top of the list, probably assertive technology, such as screen readers. So allowing people with visual impairment to be able to access online services. These people may have support with them, but it's really empowering if they can access the services by themselves. So these are the solutions that we've started to look at, and we created based on those different 4 key groups. And these are some of the project milestones. So we've launched our digital ambassadors. So that's live now. It's live on our website, where a patient can call up and book in an appointment, or they can send a form through and book in with a digital ambassador. And this is being sent out to all of our partners to let them know that their patients that maybe they're struggling with or aren't responsive, the receptionist, that they'll be able to book in with an appointment with them. We've also launched our AA+ accessibility. So we've just released a new statement on the website and done a full health check of the website and the app. We've also run our app through Orca, which is a health app website, and we've been given an accessibility rating of 84%, which has been fantastic for us. And then looking to launch later on towards July. We're just waiting for Hounslow to reopen up their town hall post-COVID, so that we can look at getting one of our physical company pods within the town hall and enabling one of the members of staff within there to be the digital ambassador. This also links in with our multiple user accounts. So this is something that we're looking at for the future. So that means, say someone in a multi-generational household, the grandson might be able to use their mobile or their laptop to help enable their grandmother, say, to have a consultation. So they could use the same device, but just have different accounts within that. So we're looking at how we can take some of the technology from the pod and bring that into people's devices as well. And then we've got our multilingual consults. So as everything we do at Push Doctor, we always start on a small scale and try and gather as many learnings to then look to scale up. So we're looking at launching our multilingual consultations with one surgery and with one language at first, to gather all the learnings, to then look at scaling this up across multiple practices within the Hounslow area, but also looking at partners. So then a wide range of different communities and different ethnic groups will be able to access video consultations and use a translator for that service as well. So hopefully within 2020, we're aiming to achieve our initial objective. So we're hoping to meet the health needs of our partners and their patients, helping to close that digital exclusion gap, but also promote digital empowerment through our digital ambassadors and helping people and support people as best we can get access to the digital services that they need. Great. So I am going to pass over to Ivor now, and he's going to talk about how it's been working with Push Doctor and how that's affected him and his patients.
Thank you, Dan and Jess. It's been amazing working with Push Doctor for the last year. So I'm Ivor. I'm a GP in Hounslow. So I've been a GP for the last 8 years. So I work with a group of practices that run 5 practices in Hounslow, but I'm the lead GP of one of the practices for 8,500 list size. So I've been there for the last 8 years in Hounslow. So I've been working closely with Push Doctor for the last year, rolling out their service as part of the Hounslow CCG model. I'll just give you a little bit of a background about our practice. Jess, would you be able to please change to the next slide, please? Thank you. So in Hounslow, as I'm sure everyone is aware, it's quite a diverse background. So we've got around 46 different ethnicities in Hounslow. So we've got, in our practice, we've got around 15% of our patients who are over 60. Large proportion of low-income backgrounds with socioeconomic problems, alcohol, drug use, percentages being quite higher than national average. We've also got around 3% of our patients who are on the learning disability or physical disability register that have been coded. Next slide, please, Jess. Thank you. So Hounslow has 5 PCNs. So I am part of the Great West Road. So Heston's part of the Great West Road PCN, which has 8 practices within the PCN. We especially felt the benefit of Push Doctor during the pandemic time, where we were having problems with access, like in all areas, I'm sure, especially in general practice, where a lot of myself and other GP colleagues were working in vaccination hubs. I was able to cancel a whole day each week to do the home visiting vaccinations for the PCN, where potentially I would have struggled to have done that. But I was able to at least this way know that at least patients would get their appointments and the list would be covered. So I think that was a significant peace of mind, especially during the pandemic time. Going forward, we've had some discussions in our PCN, and we feel that we're going to make use of the Push Doctor service to the best of our ability. And what we're planning to do is focus on chronic diseases and our enhanced services like diabetes, mental health, care planning, and potentially use that time that's allocated to the Push Doctor sessions for one of the regular GPs to help with some of the chronic disease management. For myself, for example, I do insulin management at the practice. So this has given me a little bit of a breathing space to set up clinics and run those clinics, where before I would be more worried about the emergency appointments and management of them as well. So it's given me a bit of a breathing space, which has been helpful. in Hounslow, we've also got a large impact with the pandemic, with the socioeconomic impact. A lot of our patients were employees at Heathrow, where they've been made redundant or had to take voluntary redundancy or early give up the job on an early basis. So we're issuing a lot of sick notes at the moment, unfortunately. But again, with that access, sometimes, with depression, that along with that, you get mental health and stress, and need goes up and the access as well. So I found that Push Doctor has helped offer us more access when patients need it. So rather than telling a patient to call back the next morning for an appointment, at least you've been able to tell the patient, actually, look, would you be happy if one of our other partner services contact you from Push Doctor? And so far we haven't had a patient who has declined. I volunteered to do this along with Push Doctor because I found I've had a very positive feedback from colleagues and from patients about Push Doctor. The biggest positive thing is that I found the collaborative approach with a partnership model that Push Doctor use along with the GP surgery. So they're running parallel to the GP surgery to assist the surgery. And I think that is the main benefit. But in addition to that, I found your ethos is very good in that you're concentrating on other aspects of patient care, which might not have been covered by digital providers before, such as the learning disabilities that Jess has talked about. I'm excited to hear about the pod in the town center. So we've got some patients who are shift workers and couriers and other thing with the 9 to 5 sometimes doesn't suit them, or a Saturday morning also might be tricky for them. So I think the pod working will be very interesting. The important thing is the integration of Push Doctor was quite seamless in general practice. And I think that's one of the things I was a bit anxious about, having had the e-consult system set up a few months earlier to Push Doctor. I found it was much more seamless, and it seemed like there was a GP sitting in the practice doing their clinical work rather than a lot of hiccups. So I think that was really a blessing. And also there was a named person to contact if there was any problems, and which was quickly sorted out. So I think it's been very, very positive and patients have been very, very satisfied from our end as well. Jess, are you able to next slide, please? From my side, it was just a snapshot as a user from the practice, perspective. I have found the Push Doctor very collaborative, and I would definitely recommend Push Doctor to other practices that might be looking to look at a service that runs parallel to give them their support and assistance to help patients access care, especially knowing that they're focused on targeting other groups as well, and training up patients to help make them more responsible for their health. Thank you very much. I'll pass you back to Dan. Would that be all right, Dan?
Yeah, thanks, thanks, Ida.
Thank you.
We've gone off screen share. Let me just maximize this a second. So yeah, what I hoped we did today was we talked about the problem which I presented. Jess came in with the solutions, and of course then we've got some live examples from Ida about how we've made that look different. So if I go through some of the questions that you've raised, H, you very timely raised about my digital signal. So I'm on a Wi-Fi signal here. So you're right. We've designed the system so it can work with 3G, better with 4G. And of course, if you've got a blistering fast Wi-Fi, then all the better. But it can work with 3G. But yeah, to your point, you're right. I'm sat in central Manchester, theoretically with a line that's as fast as goodness knows what, and it drops out. You can't odds that. I get that's one of those risks. Martin's talked about the next question around not speaking good English, relying on their children. Jess, could you cover that question off for us, please?
Yeah, so it's a really good point, Martin, and this is something that also you know, we've been looking at like that's an addition for us as well, you know, that someone could be able to support someone going through to a consultation. So what we found out from the research is that most people have either support or basic English, but actually when they're in the consultation, they need that medical information translated into their own language, because it helps them, and it helps them better understand their health and the questions that the GP or the doctor might be answering to them. So
sorry, yes.
Oh, sorry, no, you go for it, Dan.
I thought you'd finished it. You go, it's okay. I was going to say that's important. You talked earlier about the multi-account devices, so that's why it's important that we've got the multi-account devices, I guess, isn't it?
Yeah, so I think it's helping them on the journey, like, of the account creation and the setup, like, and maybe getting them into a consultation, but whilst they're in the consultation, you know, having that additional support of a translator would be there. Does that help answer your question, Martin?
Martin, maybe it may have gone, but yeah, I'm cool.
Yeah, and I think the next one's for me as well. So we use TUE33 guidelines for accessibility. So we have a lot of testing software that we use across the site, and we try and allow and agree accessibility to achieve AAA is like the gold standard. That's really where we want to get to. So that means that a lot of assistive technology can use your website and your app. We're hoping and we're working to get toward there. I think this will be an initiative for us each year to keep, you know, chipping away at accessibility, keep testing, keep getting information back from users about how they're using and accessing our service, and you know. I think the rating through Orca has been really beneficial and like interesting to see how we compare against other apps as well, especially other healthcare apps.
Thanks, Jess. A lot. If I theme some of the questions, actually, some people have talked around where the pods or the hubs go. Have we thought about pharmacies? Have we thought about health centres? When are they going to open? So I guess there's two things there. Either I don't want to offer something that we can't possibly furnish, but I would suggest that maybe if people were interested in seeing what's going on at Hounslow, there could be stuff to look at there. Ultimately, where you put the hub or the pod, how you use it, how you service that is absolutely up to you as the commissioner, as the PCN, whatever that person looks like. So yeah, there's ultimate flex to do that. Either, I mean, you've chosen to stick it or to utilise the town hall, haven't you? Because it's in Hounslow and it's a key focus and it's a building of multi-use. So naturally, we'll get a lot of people through. That's why you've chosen it. Is that right?
Yeah. I think that was more of a CCG decision, but from my side, I fully agree. And I think that's one of the things we can definitely look at their pharmacies also. And I think later on the line, we can always, and that's the really good thing with Push Doctor is that there's a good working relationship. I can come back to yourself and say, actually, look, you know, I think this might work better in Hounslow, and give my feedback as well. So I think pharmacies or some places have a health center, which has got, you know, which has got access to, like in Hounslow, we've got 92 Bath Road, which is like a big health center where a lot of other services run out from. So, so I think it's, you know, the important thing is that it's, you know, stats will be able to tell how many patients do use a service, which is helpful, and then things can always be relooked at. I did see a question from Hakil, and I will answer that while I'm here, if that's okay. Is that all right, Jess? Thank you.
Yeah.
So the important thing is, when Push Doctor was being set up, and I think that's one of the very positive messages from my end. With eConsult, I was battling with trying to train up reception to try and get all the processes mapped out before I could even let eConsult go live, because I was worried about, you know, who's going to tick what box and all the rest of the things. I think what caught me by surprise with Push Doctor is that everything got installed and set up and run directly by reception and administrator. And we were already live, and I was helping with the vaccine hubs and everything. And we are one of the highest users of the PCN. So I found that reception found it incredibly easy to use Push Doctor. And there was, and even if they had any queries, so I think at one point they had a couple of tasks that came through that they weren't sure what it was about, and they were able to, they had a named person, and everyone knew seamlessly who to contact if there was any concern. So it didn't come back to me and sit on my desk or my inbox for a week or two for me to action. So I think that was a really positive experience from my end. The actual technical of what it involves to set it up, I'm a little bit unsure, but I do know it was very straightforward.
Yeah, so just extending from that point, I guess that's the whole raison d'etre, to make it as easy as possible. You get a dedicated account manager. We come and do training on site for you, recognise that actually time is ultra precious for primary care. So we make it as seamless as possible. And of course, when things do happen, there's glitches, we guide you through that process. You've got a dedicated team, and of course, patients have that access too. So it's all about making the process as seamless as possible. Right, so Martin's mentioned about interpreters. Yeah, absolutely right, couldn't agree more. Had that problem myself. We have a seamless process in place there where our customer service team contact the interpreter, so everybody's online, so the patient doesn't experience undue delays, and of course the clinician doesn't either, which is really important. Fetty, I think you've asked around the assistive roles and any issues in terms of patient data protection. So I'm happy to cover off how the pod works, unless you want to do that, Jess, and talk to the pod.
No, that's fine. You go for it.
So the theory behind the pod is it's a booth that's soundproof. So depending on the level of assistive need of the service user, actually they could be supported into the pod, and then they have the consultation. Of course, if they need to be part of the consultation, then that's a slightly different matter, of course. But yeah, we've considered all of the all the guidance around that and work with the relevant CCGs and the PCNs to ensure patients are fully protected and assisted to access the services they need. So yeah, clear consideration for us, but thank you for that question. I think there was, is there another question down there? Oh no, Fetty just said thank you. There was talk about patient transport options again. Maybe one that we chat through with Ivor, but I guess some of the conversation is around about where you place the pods, because ultimately we need to put them in an area that's accessible for patients. Bus routes, all those things have to be considered, and also opening hours and how they can be accessed too. I think Ivor's covered some of that off. Any additional information you wanted to talk to around that, Ivor?
From my side, if we were doing the pods again, I would again take a vote and, in the PCN and just put, just bounce ideas, because again, you have to think about a lot of different things, as you were saying, Dan, that, the things like learning disabilities, or even physical disabilities, wheelchair access, it's pointless in putting it on the first floor of somewhere with no lift. You have to look at all of that as well. So, and also some pharmacies, for example, would be ideal, but at the moment they're doing COVID vaccines. So if you're getting hundreds of patients through the door at the moment, and then you're getting someone along there, is it the best of places right now? So but I think the most important message from my side would be, it needs to be flexible, potentially, maybe, from each PCN or CCG area that is getting the pod in to make that decision.
Yeah, I think when we spoke with patient participation groups as well, they suggested the pharmacy, but I suppose it's just that physical space. But that's where that multi-user account could come in. So if the pharmacy had a room, say, and we could, essentially put the iPad with it, they had a consulting room, then that might be something that we could explore as well. So that doesn't take up additional space. So that kind of like piece of technology could work the same as it does within the pod, but you just don't have the physical box, you just have the device. So that could be something that we explore as well, taking that multi access device outside of the kind of physical element.
That's very, very useful, Jess, because that's not something that I was aware of previously. So that is really good. And I will, I will come to you, because the benefit is also we've got a lot of independent prescribing pharmacists who are in pharmacies now. Because I've been the IP, their DMP signing them off. So so I might recommend a couple of colleagues across Hounslow, because potentially if you have, the important thing is access. And I think
Definitely.
working with yourselves to do that, I think is amazing.
Yeah, and I think the minor ailments pharmacy as well, like if we could link in with that, then that's a great service to be able to join the two up as well.
Yeah, I'd agree. And I think, as we touched on before, it does open doors for utilisation with the multi-user accounts, of course, in care homes. And if you have a home visiting team, of course, you can access the patient records fully with the access, and effectively do a virtual multidisciplinary team too. So having that availability to link a lot of people together, and very importantly, have access to the records and read and write from the record is a really important piece. So, Betty, you've asked about the pods being used before in service delivery, and have they been evaluated? No, Hounslow is our first foray into doing this. Of course, we've got all the technology behind it, as Jess talked about. So the iPad piece, or the technology that we work from, has been worked up and definitely been put through there. And we spent a lot of time and effort creating the pods so they're accessible, and they have all the sufficient requirements. But yeah, this will be our first foray into utilising pods.
We actually have a pod within our office that we've had set up just so that we could check all the requirements. So members of Dan's team have been through and had a look at the physical elements of it in terms of health, and then we've gone back to the kind of makers and just done it like a full health of how it could be accessed with wheelchairs and people with disabilities. Can more than one person sit in there? How do we deal with it with COVID as well, and looking at the implications of it there. So we have it all experienced the physical pod, luckily. So yeah, so it's kind of it will be interesting, I think, to see patients and how they use it. But like I said, something that we do at Push Doctor is we start small, like we do start small and then get the learnings and then try and help scale upon that.
Thanks, Jess. Hakila said, what's the cost for the user? Well, I mean, effectively, it's free at the point of access for the user because it's an NHS appointment. Ultimately, the charge to the PCN is the same charge as if you are buying any Push Doctor appointments or buying any locum-based appointments. So cost to the end user is zero. There's no markup on the appointment cost for using the pod. That's just to enable us to increase accessibility. Jess, can you see Amanda's question there around very rural areas?
Insects now set up, but no devices.
Asking around setup of devices and having no access to a pod, and local farms or community buildings being around 10 miles away. That doesn't feel like a blocker, but I'll let Jess talk to that and how we might address that.
I mean, that probably sounds like another challenge or another solution that needs looking at, because I suppose if the pod was set up with internet access now set up, but no device and every 10 miles to a pharmacy or community building. Yeah, I suppose one area that we could potentially look at, and we have explored, is maybe even like and this might be too far extreme, is like the rental of devices and ways that patients could rent a device from a GP, or they can be quite I think, yeah, so I think it's something that we'd have to probably take offline and look at a potential solution for that particular challenge, if it couldn't be used for a pod.
Yes, so she might have some more detail.
Okay, yeah.
Amanda?
Hi, yeah, just sort of to clarify that, really, it was more just to thank you for your point before when you said about the potential loaning of devices. There's quite a bit of rural broadband rollout going on across the country now, but we found that because these people traditionally haven't had it, they don't have the devices. So it was more just to thank you to say that kind of thing is a possibility in the future as well.
Yeah, I mean, definitely. I think now, in terms of kind of not iPads potentially, but you can definitely get can't think of the word not laptops Not mobile devices, but sorry, it's gone from my brain. But you can get some devices where, you know, like portals, so Facebook portals, that aren't, you know, the cost of an iPad, but you would also be able to use it to gain access. Tablets. Thank you very much, Ruth. Yeah, so I think, you know, having a set of those tablets maybe within a GP service that could be used, and see how someone got on with using video consultations, maybe someone that needs it most, or to people that are in really rural communities that don't often come into the town centre, could be an opportunity that we might look at, if we partnered with someone where that was a really big problem for a surgery. Keep taking the tablets. Thanks, Martin.
Well, it's interesting. So we talked a lot about rural communities. So I don't know if anybody's geography is familiar with Warrington, but Warrington is triangulated by 3 motorways. Semi-rural, I guess, but significant accessibility. Yet the additional boost we have from enabling a care home to have a tablet is just massive. You could effectively do a care home ward round in a very proactive way. Very important, you can cover multiple care homes, so you could effectively see 4 patients in 4 care homes without having to drive around. And you can do your MDT as well, so you can link in your pharmacist, your GP, etc., etc. So there's a whole host of different opportunities there too. So rurality is definitely a challenge, but it also benefits areas without that rurality too. Great, lovely. I think we're pretty close on questions now, which is fine. I think the key messaging, I guess, I just asked the 2 guys to sort of think about the sort of the main message we can deliver there. I don't mind going first. Ron, I've just put you on the spot and chucked you under a bus. But ultimately, for us at Push Doctor, it's definitely about helping to reduce inequalities and not creating an additional digital inequality. The view is that we can't do this alone. In solving some problems, it's inevitable you can risk creating others, but it's about how you create that hybrid solution to solving inequalities. COVID's made that significantly worse for us all and probably affected the most disadvantaged more. But that's something we have to keep a real key eye on. Ivor, if I pass to you.
I echo that, Dan, and I think from the practice level, I can say that this is definitely a partnership, and that model is key in general practice that we have found. So I look forward to working with yourselves ongoing in Hounslow.
Absolutely. Thanks, Ivor.
Thanks, Ivor.
Yes.
Yeah, so I think for us, it like Dan said, it's making our product and our service everyone, and trying to come up with the different solutions. You know, there's tons of challenges out there, and I think the partnership approach that we take allows us to you know, like test things out with surgeries and really use the information that we're getting from patients and from surgeries to try different solutions to help and tackle some of this stuff, which is why it's been fantastic working with Hounslow and the people within the community there.
Thanks, Jess. Jess, would you mind just screen sharing one last time for that final slide, please?
Yeah.
So, guys, unless there's any more questions about where things are, we will finish up. If you hadn't heard about anything that you feel is interesting, please get in contact with myself at Push Doctor or indeed the team at Push Doctor. My email address is on there. And actually, I think the article to look at for anybody on Medium is an article done by Georgia, who is one of our design managers here at Push Doctor, working in Jess's team. We do practice what we preach and put our money where our mouth is not. This is not just lip service. We actually do live the vision. Super important for us, which is really strong. We're now going to give you the gift of time. So rather than running absolutely into the 3 o'clock slot, we're going to give you 10 minutes of time away. So thank you very much, everybody, for attending. Massive thank you to Jess and massive thank you to Ivor for jumping on. I think together we can really help to solve the digital and indeed health inequalities. It'll just take us some time to do, but together we can achieve it. So thanks so much for joining us, guys. Good luck with everything. See you soon.